Good morning, Dr. Adhanom Ghebreyesus. Welcome to the Candidates Forum for the election of the Director General. I wish to thank you for coming for this interview today. I understand that the Secretariat has already informed you of the way we shall proceed this morning, and I propose that we start immediately with your oral presentation. You have the floor.
Thank you very much, Mr. President of the Executive Board, heads of delegations of member states, ladies and gentlemen. I was already introduced. My name is Dr. Tedros, and it's my pleasure to address you with my capacity as candidate for Director General of the World Health Organization. I am a candidate for the Director General of WHO because I believe in the power of this organization to make tangible and positive impact. Before I proceed to my written statement, I have, with the spirit of candor, would like to raise some issues maybe that I would like you to do some soul searching, because these three issues were very important during my discussions with many of you member states. The first one is on budget issue, and the second one is on emergency response, and the third one is on universal health coverage. On budget, as you know, the assessed contribution is only 20%, and compared to the 1970s, which was 80%, it's really low. But not only that, if you compare the value of the money that was contributed at that time during 1970s and what member states are contributing now, except a correction for inflation, some experts said that the contribution actually didn't increase. I don't think this is right, and that's what many people are saying. Take a business model. A business model, unless you have, or business entity, 51% of ownership, can you say you own that entity? So the question is, do we really own the WHO? Do we own it? That's the question that was coming into my mind after I discussed with you, with many of you. And I will tell you another fact. This is a New York hospital, Presbyterian Hospital, New York. It has a budget of $4.8 billion US, one hospital. And you know WHO's budget. Is this really the right thing? And many are asking, why are we not having the commitment to really own WHO, to make it truly belong to the member states? Because unless we empower WHO, and empowerment comes with resources, unless we ensure ownership of WHO, I don't think we will expect result. This is very important, and I think we need to really do soul searching. I have been listening to you. I will continue to listen to you, but we need to really discuss it candidly in the coming occasions, because it's very important and central. Ownership is important. Ownership is important. And then I will tell you the second one on global health security. Just one issue on that. The Internal Health Regulation 2005 is not being implemented properly. Its implementation is weak. And there is one thing that many member states raise. Some say because of fear of punishment, if we report early, we don't do it. And I said, what's the reason? Because we could be punished. And the world is not ready to implement the international health regulation in full. There is cherry picking. That's what they said. If you report, then travel ban is imposed. Is this the right way to implement international health regulation? You remember when Ebola struck, 3 countries were almost quarantined. But the international health regulation says there should be no impact on mobility and trade when we implement the international health regulation. It says it there. It's in the international health regulation. But we're not implementing it fully. Because when countries implement or report, the consequence is travel ban. The question here is, how do we ensure true solidarity? Are we really ready for solidarity? Or do we just go for narrow national interest and immediately act in the interest of our own narrow national interest without seeing the impact on others? I'm saying candor is necessary on this also, because organizations can only survive if there is candor, if there is honesty, if there is determination to really discuss about these issues, to listen to each other with respect, understand the root causes of the problem, for instance, for these two. Then the third is on universal health coverage. In 1947, when WHO was established, we said for health for all. In 1970, Almaty Declaration, we said the same thing. And 2016 now, fast forward, with SDGs, we're saying universal health coverage. Health for all. We're not walking the talk. Promises for more than 6 decades. What's happening here is the question of many of us. Is it a resource problem? I don't think, and many don't agree. Because countries with limited resources have done it. Many, but among those, I can mention maybe Sri Lanka. You know, they cover in Sri Lanka even cancer treatment, full. So is it resource a problem or lack of political commitment? This also needs soul searching. I'm challenging you to really listen carefully, really with honesty to each other and address these challenges. These are the 3, in the spirit of candor, that I would like to put forward to you, which are not new, but just to put the importance of really candor. And I will continue to listen to you and to be as candid as possible, because I believe unless we discuss candidly, I don't think solution can come. Unless we discuss candidly, I don't think we can really go to the root cause of the problem. Now, I would go to what people ask me why I'm running for WHO Director General position. They say, why you? And I say 4 things to them. And I will say it today. 1, I have the passion. And 2, I have the hands-on experience in leading change, both national and international. And 3rd, I have the technical expertise, the political leadership, and also the diplomatic skills that WHO needs. And number 4, I am from a developing world where the burden of ill health is really heavy, and I face the challenge myself with my communities, and we can bring fresh perspective to WHO. And also as an outsider with good knowledge of WHO's internal working environment, I can bring a fresh view also to WHO. I will start with the first one, passion. My passion for public health was ignited when I was growing as a young boy in Africa, witnessing the first-hand impacts of malaria outbreak on my community. After I graduated, I was hired by Ethiopian Malaria Control Program in 1986 and joined a team in a team in 1987 to control raging malaria outbreak in southern Ethiopia. I saw firsthand that most of the people in the community were bedridden and witnessed many deaths. That was the saddest moment for me. I remember the situation even today very vividly. Of course, we controlled the outbreak in 3 to 4 weeks with mass treatment, vector control, and so on. I not only with my colleagues tackled malaria, but because of the high prevalence at the time, I also succumbed to malaria infection. That was what emboldened my anger on malaria, and for that matter, any outbreak or emergency, and the passion for public health. And the second hands-on experience in change leadership, I started my role as a health minister in 2005, dealing with an emergency response to a massive malaria outbreak in the country. As a minister, it was a good opportunity for me to retaliate because my inside was boiling. We revised our malaria control program, prepared ambitious plans, and immediately mobilized 20.4 million insecticide impregnated bed nets in just 2 years, the largest bed net distribution in Africa at the time. We expanded indoors residual spraying coverage, expanded larval control. As a result, Ethiopia has not experienced major malaria outbreak for the last 11 years. In my ministry, as a minister, parallel to fighting epidemics, we started ambitious reform program of the health sector. The reform covered all building blocks of the health system, with service delivery, workforce, health financing, health management information system, pharmaceutical supply system, emergency response system, which included disease surveillance, detection, early response, and recovery system. In the service delivery reform, universal primary health care was the center of gravity, being primary, focused on health promotion and disease prevention. 6 years later, we had built almost universal primary health care. When we targeted to achieve this, many thought we were crazy, but we did it. At the same time, we looked into the broader public health in a comprehensive way and seek for efficiency and impact on how to impact service delivery and community engagement. We have not only developed our local innovative solutions that are responsive to our local context and challenges, but also looked to the best practices of other countries and took their lessons to revitalize our health system. These interventions resulted in increasing life expectancy at birth from 46.7 years in 1990 to 64 years in 2013. Many other indicators which I don't want to go into, but if I put just one, under 5 mortality declined by 2/3, 3 years ahead of the 2015 deadline. And the decline on HIV infection, malaria, mortality, and TB mortality was very significant. At a global level, I co-chaired PMNCH, Rollback Malaria, and UNAIDS. Of course, the most challenging was chairing the Global Fund Board from 2009 to 2011, when Global Fund was being heavily criticized for lack of effectiveness, accountability, and so on. I oversaw a comprehensive reform agenda aimed at improving the challenges. In parallel, we also established an independent panel to assess and provide recommendations, and this reform has guided the Global Fund to be effective, transparent, and accountable organization it is today. And you remember the $13 billion it raised just last month in Montreal. And the third is the technical expertise, political leadership, and the diplomatic skills I have. Reforming all building blocks of the health system requires strong technical expertise. And under my leadership, the health sector actually expanded significantly. And from just 600 health centers, we reached 3,500 health centers, from less than 1,000 health posts to 16,000. That's what I said, near universal primary health care in just 6 years that we achieved. I oversaw also training of 38,000 health extension workers, all of them women by design, to increase the utilization of services by women in Ethiopia. And the community-driven system with women at the core. And we have 3 million strong health development army that's composed of women alone. And not only that, we increased the workforce from 16,500 to 115,000. And the shortage of doctors was a problem, and we introduced innovative ways of converting regular hospitals into teaching hospitals with less investment, and increased our enrollment from 300 to 3,000. Because brain drain is not the root cause. We believed that a mismatch between supply and demand was the root cause, meaning the problem is ours, when we admitted that the solution came. That's why for the first batch now will be graduating this year, and it's 2,600, from graduating only 150 a year in the past. Additionally, I have worked tirelessly to champion country ownership so that affected countries are able to guide and inform global health discussions that affect the health of their populations. This all needed securing a buy-in from our communities, leaders at all levels, partners, mobilizing them to our goals. Very often encountered resistance. But we were able to mobilize to achieve our goals. As Minister of Foreign Affairs, I successfully helped bring together 194 UN member states to agree to the Addis Ababa Action Agenda, a historic milestone forging a global partnership to achieve and finance the Sustainable Development Goals. Glad to be associated with SDG this way, as chair for the negotiation of the Finance for Development, and eager to serve and see the outcome, health being one of the SDGs. I also played a pivotal leadership role in the AU's response to Ebola epidemic, facilitating greater country ownership, promptly mobilizing 200 Ethiopian health workers to join the African Union team, urging countries to adhere to the WHO guidelines. Number 4, the reason is, as I said earlier, as an outsider with good knowledge of WHO's internal working environment, and also as one from a developing world, I can bring fresh perspective. Someone grown up and faced the challenges firsthand can have, as I said earlier, not only the passion, but the understanding to bring a fresh perspective. And with that, I go to my vision and also the priorities. First of all, I would like to thank you, member states. I attended all regional committee meetings, all of them. I met 182 countries out of 194 bilaterally. And the 5 priorities, I will tell you, actually crystallized from that discussion. And I thank you for that. I feel like I'm reporting back to you. And I envision a world in which everyone can lead a healthy and productive lives, regardless of who they are, where they live. Achieving this vision and the Sustainable Development Goals requires a strong, revitalized WHO that's effectively managed, adequately resourced, results-driven, and led with political acumen. As we know, WHO is facing questions over its very identity and purpose. Yet, at its essence, it's an organization that has the power to change and save lives and make an enormous impact on the world. I'm standing as a candidate to become the Director General of WHO is because I know what it takes to care for those in the world who need it most and who have the least. And I know how to make sure WHO's impact is felt on the ground in daily lives. I believe in WHO's potential, and I believe I will be able to help it get there. The challenges are so broad and multifaceted that no single region or organization can manage them on their own. In order to address them effectively and save millions of our fellow citizens, we must act together. And my first priority is transform WHO, reform. And a new and challenging health landscape can only be matched by a responsive, adaptive WHO. Building WHO into a more effective, transparent, and accountable agency that's independent, science and innovation-based, results-focused, and responsive will be my first leadership priority. This transformation will require striking a balance between bold reform and the stability of the organization to deliver results. Reform and stability is very important to get things done. WHO, as I said earlier, should be empowered by having access to more assessed contribution and basket funding to use it based on its priorities. Empowered WHO will be more productive. I will ensure that our financial and human resources are focused on those areas where we can make the greatest differences for humanity. I will also create good relationship between management and staff, and I will give special attention to staff concerns and address internal good governance problems. Will motivate and inspire staff, because change comes from inside. I will work to enhance predictability and flexibility of WHO's financing by positioning health as a security, economic, and development priority through political leadership. I will establish an interministerial advisory commission composed of ministers of health, finance, and international development to solely advise and address the budget issues that we have at the moment. I believe decentralized and empowered system with appropriate accountability mechanisms brings better result. I don't believe that the current structure is a problem, but we need to continue to strengthen the global policy group. We need to have a mechanism for accountability, and we have to formalize it. If we can do this, actually an empowered and decentralized system is more productive, because not only the labor at the grassroots and at the regional level, we will use the mind, because it's an empowered person or institution that can give more. And the second priority is health for all. Today, as you know, 400 million people, 1 out of every 17 of the world's citizens, lack access to one or more of the essential health services. So when I say health for all, we need to break all the barriers. And I said it earlier, I don't want to repeat. What is important here is the political commitment. Otherwise, resource is not an issue, especially if we use universal health, if we put universal health coverage at the center. It addresses almost all issues. Even it's with stronger systems, universal health coverage, that we can fight emergencies more effectively. Then strengthening the capacity of national authorities and local communities to detect, prevent, and manage health emergencies, including antimicrobial resistance, and promote global health security will be my third leadership priority. On this, the key issue is to implement the international health regulation in full without cherry picking. And the second is implementing the new emergency response that was ratified in May 2016 in full again, but we need to have the commitment to fully finance it. Yesterday, I attended the finance dialogue, and it was not funded, but we wanted to have the emergency response in WHO. So that has to be addressed, and we should ensure country ownership and also country capacity. And the global health security agenda will also be very important to address the challenges. And the key in global health security is to implement it and to implement it. I think we don't need to go into another round of reform. We have a whole package, new design. The key thing is now implementation. And the fourth priority is putting women and children and adolescents at the center of global health development agenda and positioning health on the gender equality agenda. In too many places, gender gaps, harmful cultural and social practices, and gender-based violence are negatively impacting the health, dignity, and rights of women and girls. Countries grow, develop, and have stronger communities when women and girls are healthy and empowered. But there is a serious weakness in doing honest assessment of the challenges and their needs. We don't listen to them, and we don't ensure ownership by them. I would reorient WHO to women, children, and adolescents by increasing the focus on reaching populations in humanitarian, fragile, and hard-to-reach settings. And also, I will advocate for increased investment. The details, I think you can read it in my statement. And the fifth is health effects of climate and environmental change. Climate and environment change is a global challenge that will continue to have a severe impact on our planet and on the health of our people. We have to take it seriously. It's a real problem. It's a real challenge. Of course, the world is coming together now. We can see the solidarity. But the health impact should be taken serious, should be given serious attention. And strengthening national capacity to effectively access and understand the use of climate service is important. Research and development on climate change is important. And also I will champion the use of low carbon approaches and also funding, especially to those who are most affected, like the small islands. In conclusion, I believe that a fresh vision of the World Health Organization through inclusive partnership can make all the difference. The world must learn from those who fight every day to safeguard public health, those who have struggled and triumphed against some of the most critical health challenges. I'm deeply humbled to have received the endorsement of the African Union for my candidacy and the financial support for my campaign. I'm also grateful for many countries throughout the world who have provided the support I have received. WHO's work touches hundreds of millions of lives around the world. Every program, every initiative, every allocation of funding is so much more than a static or line in a budget. It's a life protected. It's a child who gets to see adulthood. It's a parent who watches their child survive and thrive. It's a community living disease-free, or an entire country or region that's better prepared to handle emergencies or disasters. This is the difference WHO can make, working hand in hand with member states and global partners with candor. I hope you will join me in working together for a healthier world. I'm ready to serve. I have the passion, hands-on experience, technical expertise, political leadership, and diplomatic skills to lead WHO for the 21st century. I will continue to listen, and I will make sure that our relationship will be based on candor. Without it, we cannot build good relationship, and we cannot change and strengthen our WHO. Shukran jazilan, shishe, thanks so much, merci beaucoup, spasiba, and muchas gracias, asante sana, amesegnalo in our language. Thank you so much again. Thank you.
Thank you, Dr. Adhanom Ghebreyesus. The clock has been stopped, and we shall now continue with the questions and answers. I shall now invite member states and associate members wishing to ask the candidate a question to place their blue token in the receptacle corresponding to the region. The blue token. At the same time, I shall proceed with the drawing of lots to determine the order in which each region will have the opportunity for one of its members to ask a question.
Just so you can see.
Yeah. Eastern. Station.
Right. This is the list of ambassadors we have identified.
Okay.
So you may want to recognize Okay. So if you do it on microphone. So number one? Yes. So the first region will be. Oh. You need a bigger bag.
So the first region to ask a question will be Eastern Mediterranean. Emro. The second will be the African region. The third will be the European region. The fourth will be Western Pacific. The fifth will be Southeast Asia. And the sixth will be AMRO, the Americas. We collected all the boxes. Have all member states and associate members wishing to ask a question put their token in the bags? Seems like it, so I shall now pull one token out of each receptacle following the order of regions as we have just determined. And once the 6 tokens, once per region, have been pulled out, I will invite the corresponding member state or associate member to ask the question. So we'll start with AMRO. AMRO. It's none. Empty. Okay. We'll go next. African region. That is Algeria. The European region. Germany. Western Pacific. Australia. Southeast Asia. India. And finally, Americas, yes. Uruguay. Okay, so we can start with the questions. I shall give the floor to Algeria to ask the question, to be followed by Germany. Algeria, you have the floor. Can we start the clock again, please?
Thank you, Mr. Chairman. First of all, I would like to join you in welcoming Dr. Tedros and thanking him for his brilliant presentation. in which he shared with us his vision about the future of our organization. My question is about workplace, health workplace. Health workplace is a challenge that is facing many countries. What is your experience with health workplace, workforce development that will make you unique? And what are the specific action that you will take if elected as the WHO Director General? We wish you all the best, and thank you very much.
Yeah, thank you. Thank you very much. I'm glad to have this very important question. Health workforce is very important. And in Ethiopia, maybe I will start from my experience there. What we did was we tried to understand the situation, assess the situation. And then based on the problems we have, as you know, Ethiopia, like many developing countries, it's affected by communicable diseases. Of course, even for non-communicable diseases, health promotion and disease prevention is important. Then after identifying that, we put primary health care as the best vehicle to really promote health promotion and disease prevention. And then we identified our health workers based on that. And that's why, due to shortage of doctors and nurses, the first line, like the primary health care, especially the health extension program, which has been benchmarked by others, was actually staffed by 12 graders plus 1-year training on health extension. And these are the new cadre, around 38,000, who actually brought the change in Ethiopia by doing health promotion and disease prevention. So the message here is, when you talk about health workforce, it's better to make it fit to the purpose, to what you need. And then I can give you another example. Health officers, we don't have enough surgeons or OBGYN. But maternal mortality rate is high, especially deaths during delivery because of complication. Since we don't have enough OBGYN and surgeons, we trained health officers on emergency surgery, cesarean section, and that helped reduce maternal mortality. So this is focus on task shifting was important. The third thing is, we don't blame others, as I said earlier. The workforce crisis in Ethiopia, we thought, was internal. A mismatch between supply and demand. Admitting that is very important. So that's why we designed flooding and retention strategy, and we increased enrollment from less than 300 to 3,000 in just a few years. And Ethiopia is now producing enough, and we addressed the challenge by looking inside. Then when I come to WHO, I will look for models throughout the world. We didn't reinvent the wheel in Ethiopia. We looked for best models, best practices elsewhere, and then we resolved our problems, tailoring them to our situation. There are best practices throughout the world. We can benchmark those, share it with countries.
Thank you, Dr.
And scale
Tedros.
it. Thank you.
I shall now give the floor to Germany, to be followed by Australia.
Thank you, Chair, and I would also like to thank Dr. Tedros for the presentation. Some consider the running out of the polio funding as one, maybe the largest challenge for WHO in the next future, given that currently every fourth dollar this organization has comes through polio funding. And for example, in the African region, almost a third of the WHO staff members is paid through polio funding. Many technical programs in many regions heavily depend on the polio funding. How will you address the drying out of this funding? What is your concrete plan to keep all the other programs running once the polio funding has stopped, potentially within the next 3 years? Thank you.
I think when I started my presentation with budget, by the way, that's the serious problem. And the problem is lack of commitment. But at the same time, I know people are asking for better performance by WHO, prioritization and deprioritization, and then focus on high-impact programs. I think that can be done. But side by side, countries should also renew their commitment. I don't want to go into details, I said it earlier, but for this particular, what we can do is, one, the candid discussion and also the importance of assessed contribution is important. We need to increase that, but that will take time. I have seen Margaret Chan is now the Director General, is now fighting to increase it 10%. And I believe that it should even increase more. But while doing that, we can focus on really still convincing the traditional donors to continue, because you cannot stop something in the middle of the fight. It's not right. And we have to discuss openly and candidly. That's why I said candidly. And we have to look for new donors also, and we have to broaden the base. But if we work together, I think we can fill the gap. And what I would propose here is we can assess the situation, and what I just proposed now can be taken into consideration, but we can explore for more options to address it. But it should be addressed. Thank you.
I now give the floor to Australia, to be followed by India. Australia, you have the floor.
Thank you, Chair, and thank you to Dr. Tedros for your presentation. You have indicated that you undertook major health reforms during your tenure as the Ethiopian Minister for Health. What are the most important lessons you learned from this work, and how would you apply these lessons when continuing WHO reform? Thank you.
Thank you very much. Health reform, what I learned, first of all, the reform should be as comprehensive as possible. When I say comprehensive, I already read all the building blocks of the health system. So it should cover all building blocks of the health system. And two, it should be as ambitious as possible. And three, when it's ambitious, it needs resources. And some people were saying, oh, you have ambitious plan. Why do you proceed without money? And we told them, okay, we will put the money as part of the plan. You know, we shouldn't plan based on the resources we have. We should really put what we want, and finding resources should be part of the plan. That was what I learned. And it really liberates your mind, because you're not planning with a constrained budget. You can look for the budget also. And the other important lesson is political commitment is important. Starting from our late Prime Minister, I still can't believe, and beyond words, the level of commitment to really make the primary universal health care happen. And the other is, reform always should be taken politically. It's a political issue. There is resistance very often. And from the start, you have to mobilize all involved. We started from the communities. We started from local leaders and up the ladder to convince them the importance of focus on primary health care, on universal primary health care, because everybody wanted to see a shining hospital. But we told them this is not the answer. To reduce malaria, to reduce HIV, to combat problems, maternal health, and so on, basic primary health care it can take us a long way. I'm not saying secondary, tertiary are not important. They are important, but more important is focus on prevention and prevention. And it drew a lot of resistance. So one lesson is expect resistance, and from the start, try to mobilize all stakeholders to have a buy-in. And when they have a buy-in, they help you implement it. Not only that, they bring their resources also. That's what we have seen. Be it communities, be it local governments, be it partners, after they were convinced, they came up with funding. Then with partners also, on the country ownership and so on, we had the same, we wanted them to fund the reform, and we had to have a buy-in from the start, convinced them to give us basket funding, which, the International Health Partnership, which really helped Ethiopia to implement its reform based on its own priorities, with full commitment. When there is ownership, there is commitment. When there is commitment, there is
Thank you, Dr.
result.
Tedros. I now give the floor to India, to be followed by Uruguay. India, you have the floor.
Chair, and we welcome Dr. Tedros to this candidates forum and thank for his comprehensive presentation. In an increasingly interconnected world, the challenges to public health are only mounting. AMR, emerging infectious diseases, and increasing burden of non-communicable diseases, all of them need collective efforts and innovative solutions.
India, can you slow down your question, please? I'm sorry, but...
I just wanted to focus on the question and quickly run through the introduction. But anyway, thank you. So the SDGs provide a unique opportunity to overcome these challenges, strengthen our health systems, and achieve universal health coverage. This requires a multi-sectoral collaboration and a comprehensive and integrated approach to health. While you have touched on some of these issues in the presentation, we would like to hear from you what out-of-the-box ideas and thinking that you wish to bring to WHO to position the organization as a strong partner for member states in the realization of health-related SDGs, and what would be your specific priorities in this regard? Thank you.
Thank you very much. That's a lot of questions, I think. When I discussed with member states, in addition to the 5 priorities, 3 major principles actually crystallized. And we can see your question from that angle. Number 1 was people first. If we put people at the center, what you said, the multi-sectoral, can happen. If we can convince these sectors to really put people first, and if there is honest belief in that, it can happen. Everybody should realize that health is a rights issue, an end in itself, and a means to prosperity. And this is good for all sectors. Why can't we understand this way? So the multi-sectoral approach cannot be just technical or mechanical. It's a belief that should drive us from inside. Believe in human rights, health as a right, and also as a means to development. And the second is, the world had already agreed Sustainable Development Goals to put health at the center of all global development agenda. And we have to work for that. We have to make sure that health is at the center of all development agenda. This was the second principle. And we should understand the connections between health and all the sectors. By the way, I have seen that when I chaired the Finance for Development negotiation, how all interconnected it, but health should be at the center, and it's a must to work with the other sectors. And the last one is the effective partnership. We need to have effective partnership, and WHO should lead from front and center. WHO is not a technical agency only. It's technical, but at the same time political. It's with a combination of technical and political intervention that can achieve the 5 priorities and move based on these principles. So I think this is what I will do. The political leadership will address the issues that you said. Thank you.
Thank you, Dr. Tedros. Uruguay, you have the floor.
Thank you very much, Dr. Tedros, for your presentation. Non-communicable diseases represent the main cause of mortality throughout the world, especially in middle-income and low-income countries.
Start your question, because we had some problems with translation for the candidate.
No problem.
Thank you.
Mi pregunta es la siguiente.
My question is as follows. Non-communicable diseases represent the main cause of mortality in the world, especially in countries of low incomes and medium incomes. These preventable diseases are due in great measure to 4 risk factors: tobacco, alcoholism, poor diets, and a sedentary lifestyle. On top of the loss of life, healthcare systems suffer the high expenses incurred by these diseases. It's calculated that in Latin America, this represents around 7% of the annual health expenditure. In Uruguay, we need to, as well as more broadly speaking, we need to carry out greater efforts to fight against these diseases in a more effective way. In the face of this reality, what would be your specific proposal for the international community to be able to renew its efforts against these diseases and also to help countries, especially developing countries, to help them so they can have effective policies that can reduce the negative impact? How do you see the leadership role of WHO in an initiative of this nature?
Please, thank you.
Yeah, thank you very much for that. Sorry, I was using the translation. My Latino name, my Latino friends call me Pedro instead of Tedros. I can see that in light with the universal health coverage. In universal health coverage, you read it in my vision statement, I said universal health coverage should not be one size fits all. It should be tailored to the needs of the countries. For some countries, non-communicable diseases are important: cancer, cardiovascular, chronic lung diseases, diabetes. These 4 are the major, as you rightly said, and then related to the causes behind them. So the universal health coverage for countries with priority on NCD will be used for that. For countries with priority on communicable disease, the same. And then the countries in transition can also tailor it to their need. So I think starting from the country and the region, if the universal health coverage is tailored based on the need of the country, it will address the problems that you said. But to address cancer, cardiovascular or chronic lung and diabetes, as I said during the primary health, my intervention on primary health care, the basics is important. We have to be very aggressive on health promotion and disease prevention. Of course, not undermining the need also for curative services on these areas once people are sick. But we need to really strengthen the basics. We need to do the health promotion and disease prevention. And primary health care is very important for this diseases. So for specific areas of intervention, we will strengthen our partnership, and based on the assessment of countries and regions, we will give the necessary support to address the challenges they think are important to them. Because I strongly believe in country ownership, and we should really start from there, listening, and the support should be tailored based on that. Thank you.
I shall now ask the Secretariat to merge the contents of the 6 receptacles into one, and will continue with the selection of member states or associate members until the time available is exhausted. What is it? I've got a big one.
Too many greenbacks.
It's like playing bingo, isn't it? Right. I shall now give the floor to Portugal to ask a question. Portugal, you have the floor.
Thank you very much. Dr. Ghebreyesus, at the 2030 Agenda for Sustainable Development, the international community as a whole committed to leaving no one behind. As Director General of WHO, what measures would you take in order to promote the realization of the human rights to the enjoyment of the highest attainable standard of physical and mental health for all, without discrimination, while paying particular attention to the specific needs of those persons belonging to the most vulnerable and discriminated groups? Thank you very much.
Yeah, thank you very much. That's a very important question. As you know, we have already agreed, to implement the Sustainable Development Goals. The whole world said no one should be left behind. On some issues, especially marginalized groups, there are sensitivities and polarization. And I understand that, but we have to continue to dialogue and cooperate on issues of common ground, and also continue to dialogue in order to narrow our differences. But I believe everybody will respect what it has promised, that's the full implementation of Sustainable Development Goals by 2030, and no one should be left behind. And that commitment can only come with strong political leadership also from WHO and the member states. So I think we have to continue to dialogue, work on common ground, and continue to discuss the differences that we have. And again, when we get common grounds, work on that. But it has to be, SDGs should be implemented in full, and no one should be left behind. And that should be the goal for all of us, as we have already made the commitment. Thank you.
Thank you, Dr. Tedros. I shall now give the floor to Brazil. Your Excellency, you have the floor.
Thank you very much, and thank you very much, Dr. Tedros, for your presentation. My question, which is based on your presentation this morning, essentially, I would like to indicate that notwithstanding your claim to be a candidate from a developing country, in my view, you have seemed to have espoused an agenda that is very much aligned with priorities of the North, such as approaching global health through a security lens, treating universality through a concept of coverage, not of a universal health system. You see WHO as an implementer of international health regulation, not as a standard-setting body. You focus on fragile states and hard-to-reach settings, but with very little clarity on the WHO mission in terms of the development agenda. So how can we translate your views in terms of a development candidate? Thank you.
Sorry, but the question is not clear. Can you clarify, if I may ask? Sorry.
How can you better explain your claim of being a candidate from the South, a development agenda candidate?
When you say candidate, linking it to Sustainable Development Goals?
Well, the rules to have a dialogue, but
Can I possibly try and clarify the question? During your intervention this morning, you claimed to be a candidate coming from a developing countries. The plans you put forward in your presentation, according to His Excellency, are more related to a north part, developed country type of driven agenda. So how can you claim that you are coming from a developing country and yet presenting a developed country agenda? Is that roughly what the question is? Yes?
Okay, thank you. That's clear now. Sorry, I didn't want to answer without clarity. If you take the 5 priorities, as I said earlier, I have spoken to 182 countries, and universal health coverage crystallized actually as the most priority. And coming from a developing country, that's very important. And for the developed countries, that's very important. Universal health coverage in some developed countries is not achieved because, I said earlier, lack of political commitment. But I believe countries from the north or south, if they have strong political commitment, they can implement it. And I said universal health coverage or health for all as a rights issue. There is no divide between north and south. It's for everybody. And as a representative, I mean as a candidate for WHO, not only will I serve Africa, but the rest of the world as well. And that's why I listened. And if you take the emergency response, for instance, when I put the three sticking issues, the concerns of the developing world and what the developed world should understand. No cherry picking of the implementation. Then solidarity of the North and South. That's very important. So emergency or global health security is important for all of us. Emergency or epidemics rages or affects developing countries more, but it also affects developed countries. And that's why I called for solidarity and also country ownership, country capacity building, and so on. This is true for the South, this is true for the East, or the whole world. And women, children, especially adolescents, more marginalized, by the way, in developing world. And that's why when we assessed our system in Ethiopia, we spoke to the women themselves. What's the problem? They were underutilizing the services. And the reason was cultural problems and house chores. And that's why the front line in our system, for instance, is you have static service at health post plus outreach because of to break the house chore barrier to visit families house to house to address it. And this, especially women, children, adolescents, could be very important for the South, but also for the North. So I can see the priorities are really balanced. And this is after talking almost to almost all countries. And I believe it really strikes a balance. But not only that, from my own experience also. I worked in developing country, and also I led global institutions. I have understanding of the North and South. Thank you.
Thank you, Dr. Tedros. I now give the floor to Spain. Spain, you have the floor.
Muchas gracias. Thank you, Mr. Chairman. I will carry out a question which was already sent prior, and which is as follows. I'd like to talk about the financials of WHO, and I'd like to ask the doctor what innovative financial initiatives might he implement as most realistic for WHO. Thank you very much.
Yeah, thank you. In my presentation earlier, I said I am a strong believer of increasing the assets contribution. I need to be honest with you, because it gives WHO ownership, it empowers it, and we get better result from an empowered organization with a predictable and also flexible funding. As I said, we have to really do an honest soul searching and address the root cause of that problem. That's what I believe, that's the root. And then when it comes to earmarked funding, I think WHO should get a basket funding instead. Or if there is earmarking, it should be based on the priorities of WHO itself. That's how you can ensure ownership. In Ethiopia, by the way, when I was health minister, there was money that was coming from many partners. We used to prepare 20 plans and then financial account to all 20 and reporting to 20 organizations. Then we said one plan, one budget, one report. And we said these are our priorities, these are the goals. We would like to achieve this by this, and we have also the means at hand. And for a better impact, please help us based on our priorities. And partners accepted after several rounds of negotiations. And we have to push for that. Assess contribution increase, and from volunteer contribution, basket funding is the best. We have to push on that. These are very important. And we did it in Ethiopia, by the way, I said it already, and it brought better result. And then the third is we have to broaden the base, not only traditional donors, but we need to have new donors that can help WHO. But believe me, overstretched and underfunded WHO, unless we want it to die, I don't think it will make really a better result. Overstretched, underfunded, not a good one. So the innovative financing, I think the three are important, but we can design details also, especially the new donors I said, to fully finance WHO, empower it, especially make it take ownership. Thank you.
I shall now give the floor to Estonia.
Thank you. Thank you very much for your introductory views. Yesterday, during the financing dialogue, we heard some fears that the WHO technical cooperation might need to undergo some surgical cuts if we do not step up to commit ourselves to contribute in a more sustainable manner to the WHO budget. I would like to ask you, which technical cooperation areas do you regard being the nice-to-have or so-called the pet topics of the member states in which the WHO is currently active, and you see the least value added in the organization action? Thank you.
Sorry, can I ask? Maybe if you can repeat, not clear, or if you can.
Estonia,
Yes.
can you quickly
Yes.
repeat the question, please?
Question is, which technical cooperation areas of WHO do you regard being the nice-to-have or so-called the pet topics of the member states in which the WHO is currently active, and you see the least value added in the organization's action? Thank you.
Thank you for that. By the way, WHO is now planning, as you know, bottom-up. And that's a very important planning approach. And the technical cooperation or technical assistance should be based on the country needs. So as long as countries say this is good for us, for instance, they are identifying now top 10, I think the importance of the technical cooperation should depend based on the country needs. As long as the country or region is happy with the technical cooperation it's getting, I think WHO will also be happy. So that's what should be the guiding principle. And that's why I was saying country ownership is key. Support based on country needs is key. Support based on country priorities is key. Empowering the country is key. And even with the structure I said, even empowering the regional offices is key. And based on that, we can provide the technical cooperation they need. And as long as that's their priority and that's what they want, that need-based support is very important. Thank you.
Thank you, Dr. Tedros. The time allowed for the question and answers is now exhausted, as is the total time for the interview. I wish to thank you, Dr. Adhanom Ghebreyesus, for being with us today, and I would ask the Secretary to accompany you to your room. Thank you.